Welcome to today's edition of Mental Health Matters. Today we're going to talk about pain management. I have a guest on the show who's going to give an overall view on pain management and how to manage your pain. Stay tuned. Amanda, thank you so much for being a guest on the show.
Thank you for having me.
You're welcome. I like to start off by thanking the guests because I know people are very busy and I know you are busy as well. So let's just start off with you just talking about who you are and kind of like what you do.
Okay. My name is Amanda Quam. I've been a registered nurse for 27 years. I've done a lot of different kinds of nursing, a lot of hospital nursing, emergency room, post-operative care.
Nice.
But for the last 15 years, I've been specialized in pain management. I'm board certified in pain management. And that's kind of been my love, my baby for quite a while now. I do work in interventional pain medicine, doing a number of different procedures to help people, and I imagine we'll probably talk about that a little bit.
Okay, nice. So what made you want to go into the nursing field?
It's funny, I think it wasn't one single decision, but when I was little, I was probably 5 or 6, my sister was diagnosed with a disease called myasthenia gravis, and we would take her to Stanford and Palo Alto, and our house was always messy and crazy, and I used to feel really good going into the hospital and everything was clean and organized, and that was probably the first taste I had of that. And then frankly after that I just wanted to be a plastic surgeon or a doctor. I had these grand dreams, but then realized I had a community college budget. So
nice.
I went into nursing, and thank God I did.
That's awesome.
Because it's the best profession.
So now why pain management? The area of pain management, so to speak.
Well, honestly, at the time I chose the job, it was just because it had great hours.
Yeah.
And I enjoyed doing the interventional side of things, and then just over time and learning through the process, I've just developed, I dare say, a passion for what I do. I recently received an award, and somebody asked me how long I was going to work, and I said, I'm going to work as long as they'll have me.
That's awesome.
If I hit the lottery tomorrow, I'd still do what I'm doing.
That's awesome.
Yeah.
That lets me know that you enjoy what you do.
Absolutely.
That's awesome.
Yeah.
That's awesome. So let's talk a little bit about the different types of pains, because we know that there are different types of pain that people experience and for various reasons. Let's talk a little bit about, in your opinion, what is chronic pain?
Well, there's a lot of different definitions of pain, right? Some people just use a time frame. Chronic pain can be 1 month to 3 months.
Right.
But I think the best definition is chronic pain is pain that continues past the time when you would expect normal healing to have occurred.
Yeah.
When we speak of like traumatic pain or somatic pain, some pain is just your body's normal response sending signals to your body that you've suffered injury. Chronic pain then is kind of the development of pain that lasts perhaps because of those injuries causing prolonged damage.
Yeah.
There's neuropathic pain, which is actual pain caused by damaged nerves or nerves that are sending inappropriate signals.
Yeah.
Yeah.
So with chronic pain, we know that it lasts longer than what it should be expected, so to speak. Mm-hmm. How do you think people sometimes tend to react towards that. For example, if a person get a headache and it's known that, okay, a headache should only last, it's just me throwing some out there, should only last for maybe like 4 to 6 hours. But if it lasts longer than that, sometimes people tend to jump the gun and tend to go online and find out different remedies on how to deal with this headache or whatever. So I guess my question is, what are ways that people can deal with chronic pain if it actually goes over the time limit that it's actually supposed to last, so to speak?
You know, pain is such a complex process, and it was funny as I was thinking about what I wanted to talk about today. I think really the first thing that I need to say is that pain, and one of the definitions of it is pain is whatever the patient says it is.
Exactly.
Because pain is a very personal experience. There's a number of different things that affect pain: social, secondary gains, your physical, your physical disabilities, your abilities to adapt, your mental health. So pain is different for everyone. When we talk about, say, pain's progressing from an expected time frame, it's really, how does somebody adapt? We're all going to live with some measure of pain. The truth is that we all do, right? First and foremost, I would say you need to get diagnosed. You do need to seek treatment if you're having pain that's prolonged, right?
Yeah.
And I'm not going to give medical advice or make any recommendations. I'm solely speaking from what my experience is and what my perceptions are.
Yeah.
But I think that the biggest thing to understand is that we're all balancing aging, degeneration, learning how to adapt to our the decline of our body, right?
Yeah.
And the only true way we can combat that is to stay active, to do the things that we know we need to do to stay healthy.
Yeah.
But then to balance that with understanding that we're not going to always have all the same abilities. Exactly.
And I think that's a key point too, because pain is different for everybody. Some people have a higher tolerance for pain than other people. And so you may get a situation where somebody might have a high tolerance of pain and they may be around a friend or loved one that may not have a high tolerance of pain, and when they start experiencing pain, it may be very detrimental to them, but to the other person it may be like, oh, it's just a scratch, or it's just a headache, or so I think that's always important to keep that in mind.
Absolutely. And it's important that's a really important thing, especially as a nurse. I have to understand that everybody's perceptions are real. Even if a scratch feels like a 10 out of 10 pain to somebody, that's their perception, and that's real.
Yes.
And yet then we also have to identify maladaptive behaviors, people that don't have good coping skills, because there are ways. One component of our pain management department is that we do have psychological help, because people can learn therapies to learn how to better cope with pain.
Yes. It's funny, and it just made me think about my cousin, for example. He's this guy that you would call a man's man, but I'm telling you, he does not do well with pain. And I sit up there sometimes if he experiences pain in general, whatever it may be, if he may hit his toe, if he's having a headache, it's like the world is crumbling down. And it's funny to me because I'm like, you this big, just man's
right.
tough type of guy, and this pain is really tearing you up. But that's his experience with this level of pain. To me, it may not be that bad because I do in general have a high tolerance for pain. So I kind of had to learn from those situations that, okay, I can't judge his situation based off my situation as to how I handle pain.
That's absolutely right.
Yeah.
But there is some truth. I hate to overgeneralize, but the bigger they are, the harder they fall.
Yeah,
right?
yeah.
Yes, the young, healthy guys, they're the ones that pass out from blood draws, right?
Yeah. So let's talk a little bit about acute pain.
So, I mean, acute pain, we've gotten a lot better at managing. I think if I were to tell somebody, what do I want you to take from listening to me speak is acute pain is manageable, but please understand that when you're taking medications, you should be trying, opioid medications in particular, you should be trying to minimize the length of time that you're doing that. If we're talking about post-operative pain or from a trauma, we have a big trauma hospital here. Those people are absolutely going to need opioids. They're going to need, active pain management in the beginning, but people need to understand that they should be minimizing the length of time that they're taking medication. Those opioids are not great for chronic pain. And we can talk about that in more detail. But for acute pain now, we're learning a lot of patients do well just on like IV anti-inflammatory medicines. We have these, peripheral nerve blocks. Say you get a shoulder replacement now where we're just putting a drip line in and infusing a local anesthetic into the joint and numbing the joint for the first day or two after surgery. Epidural blocks where we're putting still an opiate or sometimes local anesthetic numbing medicines into your back, but into your epidural or intrathecal space in such a small dose that it doesn't have all of the awful systemic effects and the prolonged issues that go along with opiates as an oral medication.
You talked about aging in some of your comments, because we all will have to walk down that path. Matter of fact, we all, every day we wake up, every second we live, we're walking down that path of aging. And I know that arthritis is one of the things that I kind of want to talk about. You gave a really good presentation, in my opinion, on arthritis the other day. I was there.
Thank you.
It was really, really good. And
thank you.
Actually, some of the staff members actually kind of talked about it later on.
Good.
So they learned a lot.
Oh, that's good. Thank you. I'm glad to hear that.
Yeah, so that was good. So thank you. So let's talk a little bit about arthritis. And I know arthritis can be closely associated with joint pain.
Well, and actually arthritis by definition is joint pain or joint degeneration. Then there's several different kinds of arthritis, the big ones being osteoarthritis, the one we associate with aging, which is more the wear and tear that goes with use, mileage. And so it can really occur in any of your joints and in your spine, but your shoulders, elbows, hands, fingers, knees. We all have probably at least a little taste of what that feels like to have at least an overused or worn out joint. So osteoarthritis being the one associated with aging, but then we also talked a little bit about rheumatoid arthritis, which is it has a lot of the same symptoms, but more systemic effects where you see other issues with it. It's an autoimmune disease where the body's actually attacking its own joints. It's not a repetitive use or overuse disease process, but the body chewing apart its joints. And with rheumatoid arthritis, you see more like malaise, headaches. People can have low-grade fevers or just a sudden onset of generalized achiness all over their bodies. It can be even in children. Juvenile rheumatoid arthritis is seen, and there's diagnostic tests that can be done, blood tests that can help identify that. And I think that's an important differentiation is that if you see somebody or if you know somebody that's got a sudden onset of just joint pain, generalized joint pain with maybe feeling tired and yucky, that might be rheumatoid arthritis, not just aging. And there's medications, the DMARDs or some DMARDs is a word for biologic agents that actually decrease the body's autoimmune response to help keep it from attacking itself. So I think it's important that we identify those patients early and get them treated early so that it slows the process. They're still going to have flare-ups up and down. They're still going to have some, degeneration issues, but I think we've gotten better at slowing them down.
Yeah, that's good too, because in my opinion, or I guess I should ask you this question, and then I'm gonna make a comment too. How important is it for people to be educated with arthritis and rheumatoid arthritis? Because sometimes, and I've even been in conversations before where people who are what we consider as being young or teenagers or in their 20s may start to experience pain, and the first thing that they say is, oh, I haven't used this muscle in a while, or I haven't exercised in a while, and they contributed that to that particular pain, which actually might be rheumatoid arthritis. So how important is it? It may or may not.
Well, I think rheumatoid is not as common as you would think. So I don't want to portray that we all have to worry about our. I can't believe I didn't turn my phone off. And no one ever texts me, but now, of course. But I don't want to convey the message that any aches or pains that you might feel are likely rheumatoid arthritis, because it's not that common.
Okay.
I just think it's important to differentiate the two. And actually, aches and pains in most people, even in elderly, if you wake up with a sore back, we say 80% of that pain is muscle pain.
Interesting.
And will go away on its own. When you're talking about arthritic pain, to be educated about it, I can tell you, if you live long enough, you're gonna get it. Right? And I often tell patients that I think that they should know as much, if not more, about their diseases as the doctor does.
I agree. I strongly agree.
Right?
Yeah.
But then I also, on the other hand, I see patients where they go, my dad had back pain, my mom had back pain, my aunt had back pain. I just knew I was going to have back pain. And then they're in being actively treated, and they're not doing well, they're not working, they're not coping very well with that back pain. And there's a piece of me that wonders, well, I mean, what percentage of people as they age have back pain, and then take that portion of people that their whole family had it? Is that a family biological link, or is there some sociological component to that? Is everybody in the family people that with perhaps maladaptive coping behaviors? Or probably it's a little bit of both, right? There is some genetic component to certain degeneration process, but there's also that component where maybe the people aren't dealing with it.
Right. That's interesting, because I do know that a lot of diseases or sickness or pain, whatever, could be generational, but for me, I don't allow that to trickle down on my life, because what my parents or my parents' parents have done may not be the same that I'm doing. I come from a family who does not properly eat, who does not exercise, alcoholics, drug addicts, the whole 9 yards. So for me to accept some of the physical conditions that they may experience in their life would be unwise for me to say this is going to happen to me.
Right.
Because I feel I eat pretty healthy, I exercise. I mean, there are things that I do to combat some of the things that they potentially or are dealing with at the moment. I know I had a while back, I went to the doctor, and so he was asking me all these questions and stuff, and was asking me, did your mom experience this, or is your father experience this, or is your sister experience it? And I told him, I said, look, that ain't got nothing to do with me. I understand, your profession, I understand what you're trying to do, but that does not have anything to do with me. And we went back and forth. And so the issue that I was experiencing, I was telling him that it was not that. So we went back and forth. And he, because of his background, his medical profession, I understand where he was coming from, because he was talking to me about the familiar, but I was trying to explain to him, no, I am an expert on my body.
Right.
So this is not what it was. So I did the blood test, I did everything that he wanted me to do, and of course it came back that I was right.
Yeah.
And so he's like, okay, Mr. Williams, and so I understand, but I have a hard time with just accepting that because
Absolutely, you shouldn't.
You
You should learn from your past,
Oh,
from
yeah.
your family, and you
Oh,
should
yeah.
understand that there are familial links, right? We know
Yeah.
there's familial links to alcoholism, to hypertension, heart disease. There's certain, things that you're going to be at higher risk.
Right.
Just like chronic pain for some people may just be a completely biologic chronic risk.
Yeah.
But we all then continue to make decisions
Right.
to do things to help mitigate or decrease the risk of those things affecting us.
Yeah. So how effective is dieting and exercising in combating a lot of those issues with pain that society tend to deal with?
Yeah, this is big, and of course, I mean, we've all probably beat to death the fact that diet and exercise and not smoking is important, right?
Yeah, yeah.
But in terms of pain, if you think about all of your major organs, your heart, anything you depend on to live, your heart, your kidneys, your liver, all of those major organs are all fed by large vessels, your carotids to your heart, large blood vessels, because they're not supposed to fail, right?
Right.
We want those to get circulation. The spinal cord does not have any large circulation. It's all small circulation.
Wow.
So if you're not exercising or you're smoking, you're not getting the circulation to your spine to keep it healthy.
Wow. I never knew that.
Yeah, it's important. It's probably the most important thing is to stop smoking if you're in chronic pain.
Yeah.
I know that's easier said than done.
Yeah.
But it is really important. The other thing is now, and we're really focusing a lot more on diet, is pro-inflammatory foods.
Okay.
I can't tell you what they are.
Okay.
And I think it's different for everybody.
Okay.
My grandma was 95 and she was mobile and she didn't take a single medication throughout her life.
Wow.
And was with it throughout her life. And she would say things like, I can't eat potatoes. They kick up my arthritis. Oh, tomatoes will kick up my arthritis. And
Really?
I thought she was just crazy, right?
Yeah.
Oh no, when you're young, you never believe anything they say. But now I notice if I eat potatoes, which I'll do plenty of, but my back will hurt in the morning.
Really?
It's crazy. So I think it's really important that people, and it's going to be different for everybody.
Yeah.
You pay attention to what you're eating and see if it exacerbates pain. It's just as important a component. I don't know why. I'm sure someone could explain the biochemical process, not me.
Wow.
As to why diet really matters. And then of course, when we talk about weight, if you think about 10 pounds extra on your body actually adds about between 30 to 40 extra pounds of torque to your joints when they're moving.
Yeah. Wow. Yeah.
Yeah.
I know a lady who, she's a very tall lady, and kind of, got a little bit of meat on her bones, so to speak. Mm-hmm. And she was having major joint pain to her knees. She would have a hard time walking, put it like that. Mm-hmm. And hard time climbing up, walking up the stairs, walking down the stairs, and she lost probably about 20 pounds. And most of the pain that she was experiencing, it has now disappeared.
Right. I think anybody, if you pick up a 40-pound sack of sand and carry it around for 10 minutes, you understand.
Yeah, exactly.
And I wear a lead suit because I work in X-ray. I wear like a 15, 20-pound lead suit all day. And when I take that thing off, I'm just,
yeah.
And I know I could do the same thing with another 15 or 20 pounds of myself. But, again, it's easier said than done.
Yeah.
So, but absolutely, weight is important. And I think one of the things that's important that we do is we recognize people's limitations and we understand we don't expect you to get out and run 10 miles. And actually, for a lot of people, the repetitive use, over-exercising can cause just as much damage.
Yeah.
We have athletes that come in that, maybe running 100 miles isn't the best thing for you.
Exactly.
But we often recommend pool therapy as a good thing for people because you can increase your heart rate, you can get circulation to all your joints, you can stretch, and you can increase your mobility without taking a lot of joint damage, and I think just not getting hot is a wonderful part of that too.
Yeah. So what is that? Is it just you're just stretching or pulling on something, or?
Well, it just depends on if
Okay.
you're going to an actual physical therapist
Okay.
versus if you're going in and doing an aqua aerobics at the YMCA, senior aqua aerobics. And I imagine that for most people, they just kind of need to explore what their options are, what their insurance covers, what's close to their house, what meets their time allowances.
Yeah.
On that note, too, I think if you're in pain, a good physical therapist is more important to you than a doctor. Sorry, doctors.
Well, that's, yeah.
Physical therapists have a lot of training. Most of them have master's degrees, and a lot of them now have PhDs, and they understand the body better than anybody. They can look at your movements, they can watch your gait, and then make recommendations to you, teach you exercises that will. Physical therapy isn't always going to make you better.
Yeah.
Especially because we're aging. We are wearing out.
Yeah.
But they can absolutely teach you what to do to slow the process. They can teach you the things that are exacerbating your illness. Say if you have a disc protrusion, a bulging disc in your spine, doing a lot of flexion motion is going to exacerbate your pain. Things like that.
Yeah.
So a plug for the physical therapist.
Nice. So what other therapies are out there that can assist with any type of pain?
So really important things that I think that should be mentioned is, of course, joint replacement. If you have advanced arthritis, joint replacement, knees or hips, they've gotten great at. You're in and out of the hospital within a few days. And I've seen people in their 90s go in and come out and do well.
Nice.
Knee replacements, shoulder replacements, they're really able to do a lot now. Certainly, I think you should do what you can to avoid that first, right? And you should manage it as well as you can. But if you're getting to the point where you're not doing the things that you want to do or you need to do, that's an absolute thing to look at.
Yeah.
In interventional pain, we do a few things. We put epidural steroids in where we decrease inflammation and pain in the spine, kind of coating the nerve roots that are exiting out of the spine.
Wow.
A lot of people describe sciatic pain being pain that radiates down the leg, and actually it's really pretty rare that it's the true sciatic nerve that's hurting. It's actually the nerve roots that are exiting out of the spine, and we can kind of tell which nerve roots those are by the radiation patterns. If it goes into your foot, it's an S1 nerve root.
Wow.
So we can even selectively target those nerve roots and coat them with steroid medication. Unfortunately, it doesn't change the anatomy of the spine any, so it'll just decrease the pain. It can last 6 weeks or 6 months. Everybody's different. And I think really what's making the difference is the people that are doing physical therapy are staying away from us longer. We do a procedure where we burn the nerves that are innervating the joints in the spine. The facet joints are really in your neck and in your low back, well, actually throughout your spine, but those joints take a lot of wear and tear because it's the only place in your spine that it moves, and they have I say the brake pads get worn out, right? And you don't have any real way to fix those brake pads. If you need surgery for it because you can't do you can't take it anymore, then they essentially just fuse your spine. But so what we do is we go in and burn the nerves that are innervating the joints and take away your pain. It doesn't affect motion. It's simply sensory nerves. They can and will regenerate. So again, it's not permanent, but it is significant relief. Typically lasts about a year. I've seen people get 4 years out of it.
Wow.
And then we can go in and redo them.
Yeah.
So, and that's, of course, just for facet pain, but we also, for patients that have had back surgeries where they continue to have residual pain, we put something called spinal cord stimulators in, where we take electrical leads and thread them up into the epidural space and send out electrical signals that override pain signals.
Yeah, wow.
And it's like an actual implant into the back. Certainly there's a lot of less invasive things that can be done. There's TINS units, which is an electrical stimulation unit that's on the outside of the body and kind of overrides. Heat and ice are, you know, they're simple, but they're important. Ice is better for inflammation. Heat is better for muscle spasm.
Wow.
Acupuncture, we have an acupuncturist at our clinic. And what else? Oh, there's just a myriad of different alternative therapies. I don't know a lot about chiropractics, so I won't speak to it, but I know that for some patients that's appropriate. But physical therapy.
Okay.
Keep mobile.
Yeah.
But at the same time, sometimes if your body's telling you not to do something, it's because you shouldn't be doing it.
Yeah.
Or at least you need to do it in moderation.
Yeah. That's I mean, you just said a mouthful right there. Because I like all the information you just shared, but I want to especially touch on the end of it because I think, well, do you agree? Well, I'll ask you like this. How closely associated is mental health with pain? Because a lot of times if your body tell you or your mind tell you can't do it, then your body may be telling you that you can do it. So how closely associated is mental health with pain, in your opinion?
Well, I think it's half of it.
Okay.
Don't you? I mean,
no, yeah, I do.
Yeah, if you think about it, well, for me, it's easy because I don't live with chronic pain.
Right.
I have pains once in a while where I go, whoa, if I had to feel that all day, I'd be a different person.
Yeah.
Right?
Yeah.
But we know pain causes depression.
Exactly.
And we know depression causes pain.
Yeah.
We know that immobility is a cause of pain.
Yeah.
And we know that it's a lot harder to get up and do things when you're depressed.
Yeah.
And then there's actually, as a treatment, we use antidepressants, tricyclic antidepressants, the SSRIs. And people say, well, I'm not depressed. And it isn't because they're depressed. It's because there is actually dopamine, you know, some of the chemicals that are released in your brain that can be relieved by or enhanced by antidepressants can also help with pain transmission.
Yeah. Yeah.
The other thing is that anti-seizure medications like gabapentin, Neurontin, Lyrica, some of these medications that we used to only use for seizures, we've seen good results with pain, particularly neuropathic pain, angry nerves. And what I hear a lot is, oh, I tried it and it didn't work.
Yeah.
And it's because it's a medication that kind of you need to start slowly, increase up, and stay on it for a period of time. Just like if you had an ulcer and your stomach needed to heal, you would take an antacid to decrease the secretion of stomach acid so your stomach could heal itself. Some of these neuropathic medications are quieting the nerves so the nerves can heal themselves.
Yeah.
For lack of I'm sure there's a much more complicated way to look at it, but I think it's a good way to think about, we're quieting your nerves so that they can heal themselves.
Yeah. Yeah.
But if mental health, again, we do treat patients with cognitive behavioral therapy, teaching people how to deal with maladaptive reactions. And then there's the whole dynamic of patients that are, I don't want to say not wanting to work, right? Because that's not, all of us want to be productive.
Yeah.
We all want to do things to be happy and healthy and feel good about ourselves.
Yeah.
And for some people, though, they're in positions where they can't lift rocks anymore.
Yeah. Oh,
right?
yeah. Absolutely.
And it isn't just a physical component. There's a psychological component to that.
Absolutely. I know someone right now who, is not really motivated to work at the moment because this particular individual is dealing with a form of depression. And you could just kind of tell like this person's not motivated. And so he's had a long history with medical conditions and stuff like that. And I just think his state of mind now mentally, he's not in a place where he can just maintain a full-time job. Although this person, he wants to, but it's really starting to take a toll on him mentally. So now he just kind of, and I told him, I said, well, just day by day, everything is day by day, and you eventually, get that motivation back and, get the treatment you need.
Absolutely. Yeah. That's why we treat the whole body.
Right.
We don't treat the broken part.
Right.
And you have to. You have to treat the whole body.
That's good. That's good.
And that, as we're talking about that, I kind of want to swing back to opiates a little bit.
I was just, great man, stickle. I was just going to go there. Okay.
Because I think this is part of the opioid problem, right?
Okay.
Is we had, in the 80s, we had this huge push to treat pain.
Right.
And it came from JACO, the accrediting organization, the federal accrediting organization that tells hospitals whether or not they're going to be able to get Medicare patients.
Okay.
And they created the fifth vital sign, meaning that we have to assess pain and then we're obligated to treat it, which I think is important. I think it's absolutely a necessity. I think that it was overlooked.
Yeah.
But I think now is that we've kind of swung a little bit the other way, right? So that now there's maybe this expectation that we should never have to feel pain.
Yeah.
And that would be great, and I hope we get there.
Yeah.
I absolutely think there's a possibility that we may get there.
Yeah.
But we're not there yet.
Yeah.
And so I think overprescribing started, right? I think that patients may not understand if you start taking pain medication like that, it makes it really, really easy to stop trying to get better.
Oh, I believe that. Oh, I really believe that. If
you feel better, you're kind of ignoring what's causing the pain.
Mm-hmm. Yeah.
And sometimes you may not, there may be illnesses where you're not going to get better, but they're few and far between.
Yeah, yeah.
And for those illnesses, that's where you want to kind of save your opiates.
Yeah.
I mean, I don't want to say stockpile opiates because you're going to die of cancer.
Yeah.
What I'm saying is that you begin to develop tolerances to some of these medications. Mm-hmm. They lose their value. Mm-hmm. And then you start to kind of lose your value in the world a little bit.
Yeah.
And I'm just speaking of opinion. This is not medical,
yeah.
right? This is just me seeing what happens to patients that start taking a medicine that makes it really easy to ignore everything else that's going on around them.
Yeah. So let me ask you a question, and I'm in agreement with everything you just said too. Because now the opiates is now an epidemic per se. It got out of control. People are using it, whether they need it or don't need it, and but what's in these medications that is causing people to get so addicted to them? In your opinion, just your opinion.
Well, I mean, opioids just bind to the same receptor as, oh my gosh, I can't believe kind of like endorphins.
Okay. So
if you go out and you run and you feel good and you come home and you're, right? Mm-hmm. Or even if you have natural pain, somebody punches you in the face, you start to feel better almost immediately because your body releases endorphins. And opioids will bind to those same receptors. Wow. So your body feels better. Mm-hmm. One of the problems then is with chronic pain is as you start to come off of opiates, your body will scream at you. Mm-hmm. Your body will tell you to hurt, that you hurt, even if you have absolutely no pathology in your body, you will feel pain.
Yeah.
And so it's hard. Wow. I really think that patients, if they're trying to get off opiates, they need to do it slowly, and they need to understand that they will feel pain.
Yeah.
That's a very real possibility, and absolutely they're going to have to start to kind of tease out what's their pathology versus what's this medication screaming, their neurochemistry screaming at them. Yeah. It's a complex process, and I think for a lot of people it needs to be done with help.
Yeah. Wow.
But opiates, what's killing people is respiratory depression. I think probably most people know that, but I dare say I should mention it.
So kind of explain it for people who may not know what that is?
Well, opiates decrease your respiratory drive.
Okay.
And we see that even in the hospital when we're treating patients. We count respirations when we administer medications because we see a significant drop even with therapeutic doses.
Wow.
And then if you mix them in conjunction with, say, benzodiazepines, you really then confound or increase that result.
Yeah.
And alcohol,
Yeah.
same thing, greatly increases that respiratory depression. And some people just die from respiratory depression. Others then also have marked sleep apnea, where maybe they're still breathing and they're staying alive, but then they're suffering complications from that sleep apnea.
Yeah.
They have a greater increase of heart disease. They have sleep disturbances where they wake up and they're not feeling rested because they're in the middle of the night. You know, their body is waking up halfway because they've decreased the respiratory drive.
Wow.
But then again, really, some people are dying from it, and a lot of patients are dying. I think I just read 110 people a day are dying from opioid overdose. 50% of those are prescription medication.
Wow.
For the last 2 years, the opioid epidemic has decreased our overall life expectancy.
By 2 years.
No, I think it's like 0.5 for those 2 years.
Yes. Wow. Because I know when they start dispensing, these opiates to some of these patients, I think that it was definitely a legitimate reason that they needed to take these pain medications. So at what point do you think that it got out of hand? Because, like now, I shouldn't say I know, but there are people that potentially who may not be experiencing pain. But a lot of them, they continue to get these prescriptions because of addiction. Others may continue to get the prescriptions because they can sell them out in the streets for a higher price and things like that. So at what point do you think that it actually starts to get out of hand?
I don't know the actual timeline.
Okay.
I think it's definitely been a gradual process, and there's a lot of dynamics to it. Certainly, like methadone,
Right.
which has been used for patients that are, withdrawing or they're on maintenance therapy to stay off of heroin. Methadone is difficult to dose. It has a 17-hour half-life, so it's a medication that isn't reliably, predictably broken down. It has some cardiac issues that can be associated with it. So, and it's expensive too.
Right.
So I think maybe people found a pathway,
Right.
an easier pathway to get medication. And then also, I think that we underestimated addiction.
Yeah.
Even I think our grandparents knew, I don't take that stuff if I don't have to, right?
Right.
And then now I have family members where they're like, well, my neck hurts. If I don't take that pill, I can't work.
Right, exactly.
Right? And I think there's maybe some truth to that.
Yes.
Maybe. But I think I would want to run through a whole gamut of different options first.
Right. And I know sometimes people don't want to experience the withdrawals that comes with some of this medication as well. And some of them feel like if I take it, I don't have to experience diarrhea or depression or anxiety or whatever the withdrawals may be.
Yeah.
So they continue to take it, and they dig themselves in a deeper hole.
Yeah, it's a really interesting dynamic, and I'm not an addiction specialist by
Right.
any means. I really don't deal a lot with that side of things.
Right.
But I think we've done a lot to improve.
Yeah.
And maybe we swung a little hard the other way.
Yeah.
I feel like sometimes we're maybe not. We're kind of jumping the gun on taking people off their medication. That's, again, just an opinion.
Yeah.
But that being said, we do have certain things in place now. We have what's called the CARES reporting system, so that if somebody comes in and gets a prescription medication, we can go onto a national data or maybe it's a state database. But a database, and we can see if they're doctor shopping or if they're getting prescriptions for other from other physicians.
That's good.
We require opioid contracts for people that are on long-term medications that says things like we can random test you to make sure, interestingly enough, not that they're taking other medications, although that is part of it, but more so that they are taking the medications we're prescribing rather than diverting them.
Right.
And then again, trying to get people to explore other options.
Yeah, yeah. And I think that's important too, because in our society, I think the first sign of any thing that goes wrong with our body, we run to the doctor and we want a quick fix. We don't want to feel like this anymore. We don't want our body to feel like it's not functioning at the level that it should be functioning at. So I'm gonna go to the doctor, I'm gonna get this med, and it's gonna make everything better. And so I think we've been programmed in society to continue down that path. Not to say that that's a bad thing, because medications and doctors and diagnosis, I mean, obviously these things are put in place for a reason. But there are other things that we can do that can potentially help our situation even before we get to the doctor.
Absolutely.
So to speak.
I think one thing that's important that we do is we start to help patients create a plan for what are their measures of success with pain control.
Yeah.
What is it that you want to do that you're not doing now because of your pain?
Yeah.
Is it sleep? Is it running? Is it walking through Costco?
Yeah.
It's plug for Costco. They paid me for that.
Yeah.
No. But no. Helping people identify what it is that they want to do.
Yeah.
So that when they see that I've taken this medication and I can do this now. Yeah. Because if you're simply taking medication to curl up into bed and stay there, you're starting the dying process.
It's interesting because I've known people to take Lyrica at night to help them sleep better, because they can't get sleep at night. They specifically took this medication for that purpose only.
Well, the nice thing about Lyrica and gabapentin, incredibly safe.
Okay, good. That's
incredibly
good to know.
Safe. I'm a less is more kind of girl. I got to think about it before I take an Advil.
Yeah.
I do.
Yeah.
But there's no respiratory depression. You can't overdose on them. It's a great medication to give to somebody, and they can steer the ship a little bit on it. Sometimes we say, okay, you can titrate up or down. I think for people, sometimes giving them the ability to control a little bit is important. Do I think there's better ways to sleep? Probably. Yeah. But then I've never had a problem sleeping. Yeah. So, yeah. It's hard for me to judge. I think we know exercise and diet. Yeah, it's really important. But once again, we are a society that we want things, we want the quick fix. Well, the other thing is we've gotten really good at keeping people alive a really long time.
That's true.
And our bodies are wearing out.
That's absolutely true. That's true.
It's a bummer.
Yeah, that's true.
I went water skiing with my mom yesterday. I'm 50, she's 70, and she's watching me water skiing. She's like, oh, I so wish I could still do that. And I'm like, yeah, but isn't it great? You're climbing in and out of the boat.
Yeah, exactly.
Yeah, you're hopping in and jumping in the water. Yeah. And I think sometimes we have to adjust our expectations a little bit. Yeah. Which means I might have to take some Motrin after I water ski from now on, right? But yeah, I don't know. There's no good answer to aging.
Yeah. So what do you think we could do as a society to help with kind of controlling certain epidemic when it comes to certain medication like opiates? For example, do you think we can be able to lock them up, or because a lot of times we get medications and we don't use them anymore, and we don't want to throw them away. So Let's talk about that.
He's being good to me because he knows I've got this pet project I'm doing right
Yeah,
now.
yeah.
And that is, I'm just trying to get a health education campaign going for Lock Your Meds.
Okay.
One important thing is that a lot of kids, in the national high school survey of children that had answered yes, they had taken a medication for pain that was not prescribed to them was significant. I can't remember the stat, but I want to say it was like 60% of kids.
Wow.
And most of those people had gotten those medications, or most of those kids had gotten them from basically stolen them out of someone's medicine cabinet.
Yeah.
And so one of the things that I'm working on is trying to get patients to lock up their medications. And I know that is, it's time consuming, and people want their medications accessible. So I started doing a research about this, and I found that there's actually a vial that has a combination lock on it, and that just pure coincidence. I don't know the kid, but he was from Sacramento, and he invented and patented this locking mechanism, and I think he's sold about 100,000 of them so far. But there's no real impetus to require any kind of locking mechanism yet. And so I'm doing a little study at my work to see how many people are locking up their medications and see why they're not. But my hope is that I can at least start getting people to understand that there are risks. People are coming in and taking people's medications. You can, I know a couple stories personally, a friend whose daughter was taking, the dad injured his back at work and started taking high-dose opiates, and kind of his life was falling apart, which is its own issue. But at the same time, he was accusing his wife of stealing medication from him, and it turned out that it was the daughter,
wow.
the 13-year-old daughter.
Wow.
And now she's 16 and she's addicted to heroin.
And see, this is the thing. Most people don't expect that. Like you don't expect, when you get medication, you're like, oh, I don't have to use them anymore. I'm just gonna put them up. I'm just gonna set them in the medicine cabinet. You don't expect for people, family members, or whoever, to be coming in and just kind of take these things because it's just not common practice for most people. But now,
well, and now we all take those locking childproof caps for granted. We just know that they're there.
Right, exactly.
And why couldn't it be the same for a combination lock? Someone could still steal your whole vial of medicine, right?
That's true.
But it's those quiet thefts that are happening slowly, that I think are at least preventable in that regard.
Yeah. So I know education is another way that the community or society, we can kind of help control, a lot of mishaps with these, opiates or other medication. Could just by going out there and just doing public speaking, or just even being at home talking to loved ones or family members, and things like that. I think all of us, it's kind of like when people say, or it's a quote that says, it takes a village to raise a child, and so even outside the home and different, outside the home, you got medical professions, you got programs like this, and word of mouth. We can, if we all do our part, we can kind of help combat some of these issues that are going on with medication, and maybe stories like that you share with this 13-year-old girl wouldn't happen if the father or other parents were educated to know that, let me lock this up.
That's how I feel.
Yeah.
If I had prevented that one case with my project, then I would have felt like I had done something important.
Because that situation could have trickled down to another situation, another situation, another situation.
Well, absolutely.
Yeah. So that's important.
Yeah.
Well, we've run out of time.
Oh, okay. Well, thank you so much.
Thank you for being on the show. And
I got to talk about my favorite subject, me.
Yes, yes. And that's it for today's edition of Mental Health Matters. If you like this particular show, if you would like a DVD copy of the show, or if you would like to be a guest on the show, please dial 916-366-4600. Thank you.